Welcome back, everyone. Today we're going to talk about the cardiac cycle and the pressure volume loop. We'll talk about a few features that we can draw from these two concepts, and we're going to talk about the physiology around them. So when we talk about the cardiac cycle, the heart contracts and relaxes in this thing called the cardiac cycle. And every cardiac cycle has two phases. There's the phase where the heart muscle is relaxing, and there's the phase where the heart muscle is contracting. The two terms that we use to describe the contraction and relaxation of the heart are: for contraction, we call that systole, and for relaxation, we call that diastole. So we'll use those terms instead of contraction and relaxation. So there's the things that we have to think about when we start the cardiac cycle is we have to begin at some point. And in this image, we're starting at what is referred to as late diastole. And in late diastole, both sets of chambers, both the atria and the ventricles, are relaxed. And during this time, the ventricles are actually filling passively. So blood is coming into the atria via the superior vena cava and the inferior vena cava. And the blood is passing right through the tricuspid and mitral valves, and it's happening passively. And so the ventricles are filling, everything's relaxed. And so you can imagine that the two ventricles are filling with blood. The next step is that the atria, both of the atria, contract. And when the atria contract, we call that atrial systole. So there's that contraction of the atria, and that forces the last bit of blood into the ventricles. There's a bit of variation in textbooks when they talk about how much blood is actually attributed to that atrial systole. It's somewhere between 20 and 30%. Most textbooks will say it contributes about 25% of the ventricular volume. So 75% of the ventricular volume is from passive filling, or approximately that, and about 25% of that volume is from the atrial systole. Sometimes atrial systole is referred to as the atrial kick. And so if you see that term, it's the same thing as atrial systole. The next step is that the ventricles start to contract. When the ventricles start to contract, the first thing that happens is that the atrioventricular valves close when the ventricles start to contract. And the force that's created when they start to contract is not quite enough to open up the pulmonic and the aortic valves. There's not quite enough force. So essentially what you're having is contraction with all of the valves closed. So the blood really isn't going anywhere. It's staying in the ventricle at this point in time. And because there's no change in volume, we call this isovolumic ventricular contraction. So you're having the contraction of the ventricles against all of the valves being closed. So that's the first phase of ventricular contraction, or ventricular systole. The next phase is that there comes a point when the ventricles are contracting, the force is increasing, the pressure is increasing, the pressure is increasing, to the point where it exceeds the pressure in the arteries. So in the pulmonary trunk, which is an artery, and in the aorta, the pressure that's in the ventricle exceeds that. And at that point, those semilunar valves open. And when those semilunar valves open, the ventricle is still contracting and the blood is ejected out. So it's ejected out from the left ventricle into the aorta, and it's ejected out from the right ventricle into the pulmonary trunk. And this phase of the cardiac cycle is known as ventricular ejection, because the blood is leaving the ventricle at that point. At the end of this phase, the ventricles start to relax. And when the ventricles start to relax, there comes a point where the pressure within the ventricles eventually is lower than the pressure in the pulmonary trunk and the pressure in the aorta. When that happens, those semilunar valves snap shut. And now you're relaxing the ventricle against the semilunar valves closed and the atrioventricular valves closed. So now you're having this relaxation phase that is against all valves closed. So you can imagine that there's no change in volume during this period in time. And so this phase of the cardiac cycle is known as isovolumic ventricular relaxation. Eventually, the ventricles relax so much that the pressure in the atria exceeds the pressure in the ventricles, and blood starts to flow in passively again. And that's when you get to late diastole. So those are all the phases. Some of those terms might be new, but you go from late diastole, both sets of chambers are relaxed, ventricles are filling passively. The last little bit of blood gets pushed in or gets pumped into the ventricles by the atria contracting. So that's atrial systole, or that little atrial kick. The next phase is that there is your ventricles start to contract. And when they start to contract, it closes off the atrioventricular valves. But initially, the pressure is not enough for those semilunar valves to open. So you're contracting against a closed space. And so they call that isovolumic ventricular contraction. Eventually, the pressure in the ventricle exceeds the pressure in the arteries. And when that happens, those semilunar valves open and blood is ejected out. So that's ventricular ejection. And then there is the relaxation phase of the ventricle, whereby eventually the pressure in the arteries is now greater than the pressure in the ventricles, and those semilunar valves close. So now you're relaxing against both sets of valves closed, and so that's called isovolumic ventricular relaxation. And then eventually, when all chambers are in its most relaxed state, at the very end of diastole, that's when those atrioventricular valves open up again and blood can flow in. There's a couple of sounds that you hear. There's this thing called S1, and there's this sound called S2. And so S1 is the sound of the atrioventricular valves closing. So if you were to listen with a stethoscope, you hear that lubbed up, lubbed up, lubbed up. So the first sound is S1, and it's the atrioventricular valves closing. And then the S2 that you hear is the semilunar valve snapping shut. I'm not actually sure if you'll have an opportunity to hear that. If you don't, you can always YouTube a video of what a normal S1 and S2 sounds like so that you can hear it. So this is one way to depict the cardiac cycle. There's also another way to depict the cardiac cycle, and you can do this in a graphical form. And this form is known as the pressure volume curve, or the pressure volume loop. It represents the changes in volume and pressure that happen over one cardiac cycle. What you'll notice is that the pressure is on the y-axis and the volume is on the x-axis. It's the exact same thing that we just talked about, just in a graphical representation. But we'll go through it step by step. So this is what a pressure volume curve looks like. Again, y-axis has the pressure and x-axis has the volume. Note here that we're talking about the left ventricular pressure and the left ventricular volume. You can also have a pressure volume curve for the right ventricle. The only difference with the right ventricle is that the pressures in the right ventricle are a lot lower. So this curve here would be a lot lower down. It would not be as high of a curve because the pressures are quite a bit lower, but the volumes are the same. Volumes are identical. So there's a whole bunch of little letters here that represent certain areas of the cardiac cycle. So the first one is A, and we'll notice that we have very low pressure and the lowest volume that we have. And this is actually symbolic of all the chambers relaxed, and this is very late diastole. So in late diastole, if we move along, this is where the ventricles are passively filling with blood. So ventricles are getting blood from the atria, it's just flowing in. So you can see that the volume's increasing. The volume increases to a certain point, and this is this A prime. At A prime, this is where atrial contraction forces the last little bit of blood into the ventricle. And that's that A prime to B. That is what that symbolizes. That's the atrial contraction, forcing the last little bit of blood. This area here, because this is the end of the diastolic phase, or the end of the relaxation phase of the ventricle. So I know that there's systole here. This is atrial systole, but what we're talking about here is ventricular diastole. At the very end of the ventricle being relaxed, or the very end of diastole, there's a certain maximum volume that your ventricle will have, and that's at point B. And you see that it's denoted EDV. What that stands for is end diastolic volume. So at the very end of diastole, it tells us how much blood is in the ventricle, in this case, the left ventricle. And if we go down here, we can see that the volume at point B is 135 milliliters of blood in the left ventricle. The next stage of this pressure volume loop is this vertical rise. From B to C, you can see that there is a sharp rise in pressure of the left ventricle with no change in volume. The volume is staying at 135 milliliters, but the pressure is going from about 20 millimeters of mercury all the way up to 80 millimeters of mercury. And so this phase between B and C, this is the area where the ventricle's starting to contract, where the atrioventricular valve, or in this case, the mitral valve, is closed. The semilunar valve, or the aortic valve, is also closed, so blood has nowhere to go, but pressure is rising rapidly with no change in volume. So this is isovolumic ventricular contraction between B and C. Eventually, at point C, the pressure in the ventricle exceeds the pressure that's in the aorta, or that large artery that's coming off of the left ventricle. When that happens, the aortic valve opens. And when the aortic valve opens, you start to eject blood. The ventricle is still contracting, but you're ejecting blood. And this is represented by, you're still getting an increase in pressure. You're going closer and closer to 120 on the y-axis, but the volume is decreasing. It's going from 135 now to 100, down to 65. So this phase where you're losing blood blood is leaving the ventricle and going into the aorta, that is the ventricular ejection. At the end of the ventricular ejection, that is where the ventricle starts to relax or stops contracting. At that point in time, there's still a certain amount of blood in the ventricle. You never eject 100% of the blood in your ventricle. There's always a certain number, a certain amount. And that particular volume happens at the very end of the contraction phase. And so this volume that exists at the end of the contraction phase is called end systolic volume. So if you know the volume that you began with, which is the end diastolic volume, and you know the volume that you end with, which is the end systolic volume, you can calculate how much volume has actually been ejected by just taking the amount that you started with minus the amount that you're left with in the ventricle. And that will give you the amount of blood that has left the heart in the left ventricle in one beat. That has a specific name, and that specific name is stroke volume. So at this point D now, you have the ventricle starts to relax. The semilunar valves are snapped shut, and the ventricle is relaxing, but there's no blood entering the ventricle. So it's relaxing against both sets of valves being closed. So this is isovolumic ventricular relaxation. Eventually you'll get to the point A again, and those atrioventricular valves open and blood passively fills in. The atria contract, pushes the last amount of blood in to the ventricle. That's the end diastolic volume. Ventricle starts to contract, but this force isn't high enough for the pressure to exceed that in the aorta. Eventually it gets there at point C. Blood is ejected out of the ventricle. At the end of the contraction phase or the systolic phase, you're left with a certain amount of volume, which is the end systolic volume. And then the ventricle starts to relax again. So this is the exact same depiction of what you saw in the pictorial version of the cardiac cycle. It's just a different way to describe it. In this particular instance, you can actually calculate how much blood left the ventricle. So in this case, you started with 135 mils. You ended with 65 mils in the ventricle. That means that 135 minus 65, that'll equal 70. That means that 70 mils of blood left the left ventricle and entered the aorta. So we're going to talk a little bit about how to really put this all together. This diagram seems really complicated. It is a little bit complicated. Because all your exams are online, I won't ever get you to draw this or recreate it. I could ask some multiple choice questions about it, but that would also require me to put the image on your exam. So I probably can't do that, but the concepts are very important to know. So I could ask you concepts from this diagram. And so this puts together everything. It puts together this pictorial view of the cardiac cycle, which is what we already saw. And it also puts together these graphs of what's happening to the ventricular volume, what's happening to the atrial pressure, what's happening to the ventricular pressure, which is the red curve, and what's happening to the aortic pressure. All at the same time, it's also telling us what is happening with the electrical activity in the heart as well. So let's have a look through this diagram piece by piece. So the first thing that I want you to notice here is that the electrical activity from that ECG that we talked about, there's that atrial depolarization, ventricular depolarization, ventricular repolarization, and then you get the same thing. You get atrial depolarization, ventricular depolarization. What I want you to notice is that atrial depolarization begins slightly before the contraction happens. Note that the electrical activity is increasing in those cells slightly before the atria start to contract. This is important. This is an important concept to understand, that it takes some time for all of those ions, the sodium ions, to go in to depolarize the cell, the calcium ions to come in and start to bind with the actin and myosin before the contraction can happen. So the depolarization happens just before the contraction happens, because it takes some time for that calcium to enter the cell, for that calcium to go and bind to the troponin, to pull the tropomyosin away, to allow actin and myosin to have their cross bridges, and for the power stroke to happen. So depolarization happens slightly before, and you can see it's a common feature. Even with the ventricular depolarization, it happens slightly before the contraction phase of the ventricle starts. So just keep that in mind. The next graph that we're going to look at is what's happening to the ventricular volume. And it kind of makes sense. So what we have in this orange part is ventricular diastole. Actually, this is late diastole. Everything is relaxed. This is where you have passive filling of blood. So the ventricles are passively filling with blood. Once you get to atrial systole, remember the atria are pushing in that last bit of blood. So your volume is increasing. So you have that volume increase here during atrial systole because the atria are pushing in that last 25% of the blood. The next you'll notice that there's a little plateau line here. There's no change in volume. And during that no change in volume, it's during the time that you're in ventricular systole. So the ventricles are starting to contract, but there's no change in volume in the ventricles. So that is the isovolumic ventricular contraction that we talked about, both on the pressure volume loop and on the pictorial graph. So that's isovolumic ventricular contraction. Eventually, you're going to exceed the pressure in the aorta, and the volume is going to be ejected out of the ventricle. So when the volume leaves the ventricle, you can see that this volume curve is going downward. The volume's leaving until a certain point that the volume stays static. And that the volume stays static or doesn't change during the first part of the relaxation phase of the ventricle. And so during that first phase of relaxation or diastole, that is the isovolumic ventricular relaxation. No change in volume, but there is relaxation in the ventricle. Eventually you get to the point where those atrioventricular valves are open and blood starts to passively fill in the ventricle again. So passive filling of blood. Eventually, the atria contract and push the last little bit of blood in, and then we're back over to this side of the curve. It's just a constant repeated curve. This curve just repeats over and over again. You may need to go through this a few times to really understand exactly what's going on, but that's the left ventricular volume curve. So now we can add on what's happening with the atrial pressure. So the atria are fairly low pressure chambers. And while the ventricle is passively filling with blood, there's really no change in the pressure in the atrium. The blood is leaving the atrium, going into the ventricle. Blood is also flowing into the atrium from the, in this case, it's the left atrium. So it's flowing in from the pulmonary veins. And blood's entering the atrium, but it's leaving also. Really no change in pressure. During atrial systole, you're now contracting the atrium and you're increasing the force with that force of contraction is occurring, and the pressure in the atrium during that time rises slightly because of the contraction in the atrium. After the atrial systole phase, Now you're into this ventricular systole phase where you have no change in volume in the ventricle. So this is the isovolumic ventricular contraction, and the valve is now closing. So you have the atrioventricular valve closed, and as the pressure increases within the ventricle because it's contracting, you get a small increase in the pressure in the atrium. This is due to a couple of things. The blood is still entering the atrium, but also that pressure on the valve kind of goes in a little bit backwards, and it increases the pressure within the atrium. During ventricular systole, again, there's really, during the ventricular ejection, when blood is leaving the left ventricle, you don't really have much in the way of change in the left atrium. There's a fairly low pressure within that chamber, and you'll actually see that low pressure. It rises slightly because blood is entering the atrium, but it doesn't ever rise significantly. Eventually, when the atrioventricular valves open again during ventricular diastole, where blood passively fills into the ventricle, you're losing volume in the left atrium. And so that volume is going to decrease in the left atrium, and you're going to decrease the pressure in the left atrium because there's a decreased volume. There's a decreased liquid volume in there. And so this sequence of events occurs over and over again, just like the ventricular volume, left ventricular volume. We'll throw on the left ventricular pressure loop now. So now we're going to see what's happening with the left ventricular pressure. And we'll see that at late diastole, there's really no increase in the pressure. You're having passive filling of the ventricle, but there's really no significant increase in the pressure within that chamber. During atrial systole, you're forcing about 25% more blood into that chamber. So that will increase the pressure in the left atrium or in the left ventricle slightly. So this is left ventricular pressure. During isovolumic ventricular contraction, you can see that the pressure in the left ventricle rises significantly and quickly. It goes from a few millimeters of mercury all the way to almost 90, a little over 90 millimeters of mercury. And this is that isovolumic ventricular contraction. The contraction phase continues. It continues, and eventually, and this will increase the pressure within the ventricle. Eventually, this curved area of the left ventricular pressure line represents the fact that yes, you're increasing the force of contraction, but you're also decreasing the amount of volume in the ventricle. So there seems to be this decreasing in the pressure, but that's because you're also decreasing volume. Eventually, your contraction phase ends, and now you're into this early diastole, where you have relaxation, and it's quite dramatic relaxation. So you get a dramatic decrease in the pressure within the left ventricle. Eventually, that pressure decreases to the point where the atrioventricular valve can open again. So the mitral valve will open, and blood will start to passively fill the ventricle again. And it'll passively fill until the atria contract, and it'll pump the last little bit of blood into the ventricle. So you can see that there's a dramatic increase in the pressure within the left ventricle. If this were a right ventricular curve, there would not be as dramatic an increase in the pressure because the right ventricle pumps at a lower pressure than the left ventricle. It's a lower pressure circuit. And so we can see what happens when we put together the volume curve with the pressure curve. So we see that there's the passive filling. You see that there's the last little bit of blood from atrial systole put into the ventricle. Here's the isovolumic ventricular contraction, dramatic increase in the pressure without any change in volume. And then there's the ventricular ejection phase, whereby you have blood leaving the left ventricle, but you're still contracting. You're still in the contraction phase. Eventually, the contraction phase ends, and you're at the diastolic phase, first stage of which is isovolumic ventricular relaxation. And then eventually, you are going to get passive filling of the ventricle again. So really no significant change in pressure in the ventricle, but a significant change in volume. There's a couple of little points here that there's point E and F. So you can see that E is that maximum amount of blood that's in the left ventricle. So that is and that happens really, that should be at this point here. It's the same volume at where they have it located. But that point in time is the maximum volume at the end of the diastolic phase of the ventricle. So that's the end diastolic volume. And then F is the amount of blood that's in the ventricle at the end of the systolic phase. And so that is the end systolic volume. So exactly the same two values that we saw on the pressure volume curve. So one of the last curves that we're going to throw on here is the aortic pressure curve. And the first thing you'll notice is that at all periods of time, the aortic pressure is quite high. And that's true of most large arteries of your body. You're going to always have a fairly high pressure. And that is related to the fact that there is significant amount of smooth muscle within the arteries. And there's also a significant amount of connective tissue. There's elastic tissue. There's a significant amount of collagen that, along with the smooth muscle tone that's within those arteries, will maintain a high pressure. So it's a high pressure circuit. And so you can actually see here that if early on, when we're in late diastole during atrial systole, the pressure in the ventricle is a lot lower than the pressure in the aorta. And then during that isovolumic ventricular contraction, there comes a time where the pressure in the ventricle exceeds the pressure in the aorta. And this is where the aortic valve opens. So it's at this point A, that the aortic valve is open, and blood can now leave the left ventricle and enter the aorta. And so you'll see that the curves now follow the same path. The aortic curve and the ventricular curve follow the same path. And that's because now it's an open circuit. So the pressure is the same in both of them. And the pressure of the blood that's going in is exactly the same as the pressure now within the left ventricle. And eventually, there comes a time when the ventricle is going to relax. And when it starts to relax, the pressure within the ventricle now is lower than the pressure in the aorta. And at that point in time, the aortic valve closes. And so the ventricular pressure continues to drop, and this is isovolumic ventricular relaxation. But the pressure in the aortic stays quite high. And that's because the tone of the muscles, the elastic tissue, and the collagen all contribute to the aorta being a high pressure circuit. So the pressure in the aorta always stays high compared to the left ventricle. You can see that it only goes down to a few millimeters of mercury at the end of within diastole. So all of these particular curves together really do make sense, but it will require you to go through them a few times to really understand the ins and outs of them. If you look at the point A, this is where the aortic valve opens. Point B is where the aortic valve closes, and there's a little notch that you get on at B, and this is called the dicrotic notch, and that is due to the closure of the aortic valve. If you look at point C, this here shows that this is where the pressure in the ventricle exceeds the pressure in the atrium, and it's at that point that the semilunar valve, or not the semilunar valve, the atrioventricular valve, like the mitral valve, closes so that no more blood enters the ventricle. And at point D, you can see that there comes a time when eventually the ventricular pressure is lower than the pressure in the aorta, or meets the pressure in the aorta, and that atrioventricular valve or the mitral valve opens. So at point C, that's where the mitral valve closes. At point D, that's where the mitral valve opens. So you can see why it's important to understand your anatomy and to know it well, so that you can, when you hear mitral valve, you don't necessarily have to think, okay, where is that valve? So you should know it's between the left atrium and the left ventricle. The aortic valve is between the left ventricle and the aorta. So you should know your anatomy. It makes understanding what is happening at point A, B, C, and D a lot easier. And it makes understanding this cardiac cycle a lot easier, because it's imperative to know what valves are opening and what valves are closing. So you just may have to go through this a few times to really hammer home the concepts. And there are a lot of diagrams that break this into sections. I'm not going to go through these little sections here because I've already gone through each curve individually, but try to go through these on your own and see if you can make sense of everything that's happening at every point in time and line it up with exact parts of the cardiac cycle. And if you have questions about that, definitely ask. But before you really try to truly understand this, make sure you know your anatomy of the heart and all the valves. It's essential. If you understand this diagram, you will understand more than you'll ever need to know about the cardiac cycle. So you'll be well on your way. Okay, so we're going to talk a little bit about some features that we can gain from understanding the cardiac cycle. So we're going to talk about stroke volume, something called, which we already talked about. We're going to discuss something called cardiac output. We're going to discuss a little bit on heart rate, and we're going to talk about factors that affect these values. In addition, we're going to go through, perhaps we're going to go through a little bit on the blood vessels and intro to blood pressure, but we'll see where we get to. But let's talk about stroke volume first. We've already discussed this. It's exactly the amount of blood that is pumped out by one ventricular contraction. It is almost always measured in milliliters per beat. And you can calculate it by taking that end diastolic volume and subtracting the end systolic volume. That'll give you stroke volume. There's also another value that we're interested in within cardiovascular phys that's called cardiac output. And this is the volume of blood that's pumped out by one ventricle per some unit time. And usually that unit of time is per minute. So the way that we calculate cardiac output is we take the number of times that the heart is beating, or the heart rate, and we multiply it by how much blood is being pumped out per unit time. And so we know that cardiac output will be the heart rate times the stroke volume. So if we look at an average stroke volume of about 70 mils, and an average heart rate of about, I don't know, 72 beats per minute. If you calculate that out, 70 times 72 is equal to 5,040. So 5,040 mils per minute, or about 5 liters per minute. So the average cardiac output for the average adult human is about 5 liters per minute. There's obviously things that are going to change that, but in general, a healthy human on average has a cardiac output of 5 liters per minute. So one of the factors that can change the cardiac output is, imagine that the heart is contracting harder. If it contracts with more force, that means that more blood will leave the ventricle per beat. And if you have more blood leaving the ventricle per beat, that means that your cardiac output will increase. Or if you imagine that the heart is contracting faster, if more blood leaves the ventricle, if blood is leaving the ventricle more times per minute, then your cardiac output will go up. And so if we look at the equation of cardiac output, I just went back a slide, we can see that both the heart rate and the stroke volume are direct relationships. They're on the same place in the fraction. So there's nothing on the bottom of this fraction. So they're direct relationships. As heart rate goes up, cardiac output goes up. As stroke volume goes up, cardiac output goes up. If either of those volumes go down, cardiac output goes down. So there's a few things that we need to talk about in terms of what will regulate heart rate. A normal resting heart rate in an average adult human is 60 to 100 beats per minute. Notice that I said adult. Kids have a much higher heart rate, and infants even have a higher heart rate. The heart rate is initiated by those autorhythmic cells, those ones that are going to automatically create the action potential. If they're going to create action potentials faster, the heart rate goes up. If they initiate action potential slower, the heart rate goes down. And in order to understand how the heart rate is regulated, you need to remember those funny channels that are going to contribute to that pacemaker potential, that slow drifting up until you reach threshold. So those funny channels. And there are a couple of things that will help determine how quickly that pacemaker potential reaches threshold. And the major factor is the autonomic nervous system. So both branches of the autonomic nervous system, both the parasympathetic and the sympathetic, both regulate heart rate. And they do this by changing the pacemaker potential. In your slides, it will say the pacemaker potential, but in this presentation, it says membrane potential. So sympathetic nervous system, fight or flight, will increase heart rate. Parasympathetic nervous system, rest and digest, decreases heart rate. And we're going to talk about how this happens. So the parasympathetic nervous system, it works by releasing acetylcholine. That's a very high-level overview of it. And it uses a special type of receptor called a muscarinic receptor. And muscarinic receptors, they exist in a lot of places in the body. They exist in the lungs, they exist in the eye, they exist on the autorhythmic cells of the heart as well. And if we look at what happens when parasympathetic nervous system activity increases, so you'll have some sort of stimulation of the parasympathetic nervous system, that will release acetylcholine, and that acetylcholine will bind to the muscarinic receptors on the autorhythmic cells of the heart. What that does is it causes there to be an increased potassium efflux from the autorhythmic cells, so that repolarization is going to be more pronounced. That repolarization phase is more pronounced. And there's decreased calcium influx. And so that depolarization phase is going to be less pronounced. What this effectively does is it causes hyperpolarization of the cell. And if you hyperpolarize the cell, it decreases the rate of depolarization by increasing the amount of time that it takes for the pacemaker potential to reach threshold. So let's look at a normal heart rate in gray. This is a normal autorhythmic cell. So you have your funny channels open, you reach threshold, remember it's calcium channels, not sodium in an autorhythmic cell. Calcium channels open and you get depolarization. At the peak, calcium channels close, potassium channels open, and you get your repolarization phase. Well, there's an increased efflux. So normally your potassium channels would close here and your funny channels are open. But let's look at what happens with parasympathetic nervous system activation. Notice that we're below where we were before. So we're hyperpolarized. And the reason for that, and it takes longer to actually reach threshold, so you get your depolarization phase, well, you have this increased potassium efflux. So there's more potassium leaving the cell. So it actually brings you to a lower threshold or lower membrane potential. So this pacemaker potential takes longer to reach threshold. So in the time that this normal heart rate beat 3 times, this blue outlined heart rate for the parasympathetic nervous system, it only beat twice. So it begins at a lower membrane potential, takes longer to reach threshold, and therefore the amount of discharges per minute is going to go down. So your heart rate goes down with parasympathetic nervous system control. Sympathetic nervous system uses a different neurotransmitter. It uses norepinephrine, and it uses a different type of receptor. It uses what is referred to as an adrenergic receptor and comes from the word adrenaline. And there are 2 types of adrenergic receptors that you have in your body. There are alpha and beta types. Adrenergic receptors, again, also exist in many places in the body. They exist in your blood vessels. They exist in your eye. They exist in your heart, so on the autorhythmic cells of the heart. And the type of receptor that you have on the autorhythmic cells of your heart are beta receptors. And it's specifically beta 1 receptors that you have. So if you get something that increases your fight or flight response, this sympathetic nervous system activity is going to increase. You're going to get release of norepinephrine. The norepinephrine is going to bind to beta 1 receptors on the autorhythmic cells of the heart. And these autorhythmic cells are going to respond by increasing the amount of sodium influx from those funny channels and calcium influx during the depolarization phase. And that will increase the rate of depolarization and therefore increase the heart rate. So if we look at, again, the normal curve, there are 3 heartbeats. There are 3 depolarizations in this time period. Well, with sympathetic nervous system activity, you get an increase in the amount of sodium that's going into the cell from the funny channels to cause that drift to be more pronounced, and you reach threshold quicker. You're going to depolarize quicker, and during your repolarization phase, your sodium is going to start entering the cell faster. And so the pacemaker potential increases at a faster rate. So you reach threshold faster. So you can see in this case, you have about 5 heartbeats in the time that a normal heart would only beat 3 times. So it takes less time to reach that threshold. And therefore you're going to get an increased heart rate. So that's how heart rate can be changed. So on an exam, I can always ask you, if you increase parasympathetic nervous system activity, what will that do to your cardiac output? So you have to think about it in two layers. So then you'd have to think about parasympathetic nervous system is going to decrease heart rate. Heart rate is a factor that directly is related to cardiac output. So you decrease heart rate, you decrease the amount of blood that's leaving the ventricle per unit time, and you decrease the cardiac output. So I can ask a whole different types of questions related to the nervous system. So now we've talked about heart rate, but now we have to talk about factors that influence stroke volume. And factors that influence stroke volume are, it's directly related to the force that is generated by the heart during contraction. And so the force of ventricular contraction is determined by a couple of things. It's determined by the length of the muscle fibers, how much they stretch, and B, how much they contract. How is their ability to contract? And so this contractility is the intrinsic ability of a cardiac muscle cell or muscle fiber to contract. It's a function of the calcium interaction with the contractile filaments, but there's also other factors that are involved in the idea of how much force does the ventricle contract with. And there is this thing called the length-tension relationship. Essentially what it says is that the more blood that flows into the ventricle, the more the muscle fibers stretch, and the more forceful your contraction is. So if you have a little bit of blood going into the ventricle, you're not going to get a very forceful contraction. If you have a lot of blood going into the ventricle, you're going to contract with a higher force. And it makes sense because if you have more blood going into the ventricle, you want the majority of that blood to be pumped out. You don't want blood to be backing up. That would be a problem. And this length-tension relationship holds true even in the absence of any kind of nervous system input. So this is true just for the heart itself. It's an intrinsic aspect of the ability of the heart to contract. The degree that the ventricle stretches before contraction starts is called preload. It's something called preload. So if you ever see preload, it's the amount that the ventricle has stretched. And essentially what two researchers discovered is that, and this is by Frank and Starling, and so it's called the Frank-Starling law. They say that the stroke volume, the amount of blood that's pumped out by the ventricle, is proportional to the end diastolic volume. And so what we're doing here is we're essentially looking at force to stretch. And so the force of contraction in this particular diagram is being determined by what the stroke volume is. So if there's more blood leaving the ventricle, there had to be a higher force of contraction. And the stretch on the ventricle is indicated by the end diastolic volume. The more blood that you put into the ventricle, the more the ventricle is going to stretch. And so when we talk about, when we look at this graph, what we're seeing on the y-axis is the stroke volume, but that's really just a way to describe force of contraction. And on the x-axis, we're looking at the end diastolic volume, but really that's looking at the amount of stretch. And we can see that as your stretch increases, so as your end diastolic volume increases, the amount of blood that you're pumping out per unit time seems to increase. And there is a maximum. Eventually, you're going to very quickly drop off, and you're going to go back to a stroke volume of 0. There's a very good reason for that, and I'll describe that reason in a second. There's actually a good reason why there seems to be this stretch force relationship, or the stroke volume is proportional to the end diastolic volume. and I'll draw it out for you. But before I do, somebody then asked, is this, even though this relationship holds true without any kind of nervous system input, someone asked what would happen if you added norepinephrine. And so somebody added norepinephrine, and there is a curve here. The blue curve is without any norepinephrine. And the red curve is with norepinephrine. So you can actually see at any given end diastolic volume, if you add norepinephrine, your stroke volume is higher than it would have been if you had no norepinephrine. So norepinephrine, we know, is a factor that will increase the force of contraction. And in medicine, in physiology, any substance that affects the contractility of the heart is referred to as an inotropic agent. So we would call norepinephrine a positive inotrope because it increases force of contraction. And so anything that affects contractility, we refer to as an inotrope. If it increases it, we call it a positive inotrope. If it decreases it, we call it a negative inotrope. And so inotropic agents, we say that they cause inotropic effects. So we would say norepinephrine causes positive inotropic effects, or we would say norepinephrine is a positive inotrope or a positive inotropic agent. So the question here is, why do we have I'm going backwards here. Okay, so the question here, I am going backwards for the Frank-Starling law. The question that we have here is, why is this even a thing? Like, why does increasing the end diastolic volume increase the stroke volume? Why? And so I'm going to attempt to draw this out. I'm going to share a different screen with you. Let's see, I think it's this one. Perfect. Okay, so you should see this. So the reason for this, it actually comes down to a couple of things. So the first thing that it comes down to is there's a certain amount, so you have a heart muscle cell. So you have a heart muscle cell. And this heart muscle cell, when blood goes into it, it tends to, when blood is going into the ventricle, so this is in the ventricle, this heart muscle cell is going to stretch out. So there's a certain amount of stretch that happens in that heart muscle cell. So this is a heart muscle cell. Sometimes also referred to as a cardiac myocyte. Myo meaning muscle, cyte meaning cell, cardiac meaning heart. So it's exactly what its name implies. And what they're saying is that the more stretch you have, the more force that you generate. And that is true up until a certain point. So here we have our end diastolic volume and our stroke volume. And what we're seeing is that there's this curve that exists on this graph that looks something like that. That as you increase your end diastolic volume, eventually this curve really drops off very quickly, and you go to a stroke volume of 0 eventually. If you put too much blood in the heart, I mean, the heart just can't deal with it. So, but we're going to look at why this is. So let's look at what happens if there is very little blood in the left ventricle. We're gonna look maybe at this point here. Very little blood in the left ventricle. And so in order to understand how we can look at the amount of force that's created, we're going to look at what the muscle fibers look like. And we're going to look at the specific proteins in those muscle fibers. So we're going to look at the myosin and actin and myosin. And so say that you have your myosin molecule, and I know that they were blue in your previous slide, so I'm going to make them blue as well. So we have some myosin. We have some myosin. I'm actually going to throw a few more myosins in there. And this is with very little blood in there. So the myosins are kind of all cramped together. The actin filaments are they are also kind of cramped together. So the actin filaments are really overlapped. There's very little opportunity for these myosin heads to interact properly with the actin. And so if you can't really have, if the myosin's very crowded, so myosin is crowded, and it can't interact with the actin, then what you're going to get from that is very little ability to contract. You can't really make this much shorter. It's already all cramped together. So very little force of contraction. Let's look at what happens maybe when we start increasing the end diastolic volume. So now we have more blood in the left ventricle, and we now have a little bit of stretch. So let's see what happens when we have a bit of stretch. So these muscle fibers are now going to be a little bit stretched out. And you have your stretch on them. Those actin filaments are also a bit more stretched out. And what you get, so now they're not overlapping nearly enough as much. They're actually not going to overlap at all. And eventually what you see here is that the myosin has a lot more opportunity to interact with the actin. A lot more opportunity. And there's no overlapping. There's little crowding. Some of the myosin might still be a little bit crowded and might not be able to bind nearly as well as it could, but it's a lot better than this. A lot better. So what you get is more myosin actin interactions, and you get less crowding, and the end result of all this is that you get more force of contraction. All right, let's look at what happens if we go, and the myosin actin interactions will just keep getting better and better and better as you move up this curve. Eventually you reach a point where this curve goes very much to zero, where your stroke volume is actually going to be zero. Let's look at what happens when we're at a stroke volume of zero. So even though the end diastolic volume is really high, we still have a stroke volume of zero. So let's look at what is happening in that instance. We still have our myosin here, have our myosin. And excuse the drawing, it's not the greatest. But now imagine this cardiac myocyte is so stretched out that the actin is way over here. There is absolutely no opportunity for this myosin to bind to the actin. It's so stretched that no myosin actin interactions. And if you have no myosin actin interactions, you will have zero force of contraction, zero force. And if you have zero force of contraction, your stroke volume is zero. You're not pumping any blood out. And so, yes, the more you stretch, the better interactions you get between myosin and actin, until the point where it's stretched out so much that the amount that you can actually have is too far. It's so far stretched out that you have zero interactions. And so that's the pictorial representation of what is happening from a more molecular standpoint and why the Frank-Starling law is a thing. So I'll go back to the slides here. There we go. Okay. So another factor that really affects stroke volume, and it's not really part of our equation where we have heart rate plus stroke volume, but it is something that will indirectly affect them. Something called venous return. It's the amount of blood that returns to the heart from the venous system. So from the superior vena cava, inferior vena cava, how much blood is actually coming back. The more blood that returns to the heart, the more blood that needs to be pumped out of it. And so that's the general rule. And so if you have an increased venous return, your cardiac output has to increase under normal circumstances. If it doesn't increase, that blood is going to start backing up, which is a whole problem in itself. Skeletal muscle also plays a role in stroke volume as well. Stroke volume is played. Skeletal muscle plays a role in stroke volume because the majority of your skeletal muscles surround big veins, and when your veins don't really pump blood to the heart, it actually relies on contraction of muscles around them to push the blood back toward the heart. And so the more skeletal muscle contraction you have, the more blood that actually goes back to the heart, and that will increase your venous return, which means that you have to increase the amount of blood that you're pumping out of the heart. So that's also going to play into your stroke volume. There's also this thing called the respiratory pump. So when you breathe in, the pressure in your lungs decreases, and you have major vessels in your thoracic cavity. And so what this does is when your pressure is decreased in your lungs, the pressure is taken off of all the veins in the lungs, and that actually increases the amount of blood flow back to the heart. So the respiratory pump also increases your venous return to the heart, and that will also affect your stroke volume. So these are a lot of factors that play into your stroke volume. One thing that I want to talk about before we end this section is the concept of afterload. And afterload is the pressure that the heart has to overcome to circulate the blood. And so, for example, high blood pressure in the aorta, the heart has to expend considerably more force in order to pump the blood into the aorta, because that semilunar valve isn't going to open until the heart overcomes the pressure in the aorta. And so that idea of the pressure that the heart has to overcome to circulate the blood is called afterload. So if you see that in your textbook, that's what it's referring to. And so here's a really nice summary of all of the things that affect cardiac output. So cardiac output we know is a function of the heart rate and the stroke volume. And the heart rate is determined by the rate of depolarization in the autorhythmic cells. If you have a decreased rate of depolarization, you're going to have, that would be due to parasympathetic activity, that would decrease your heart rate. If you have your rate of depolarization increases, that would be due to sympathetic activity. And with your heart rate changing, that will change your cardiac output, depending on what way it changes. Your stroke volume is a function of the contraction in the ventricular myocardium. So each cardiac myocyte, the force that it can generate influences the amount of blood that is pumped out. And so this force within the ventricular myocardium is influenced by two things. It's influenced by the contractility of the heart, so we talked about that. And it's also influenced by the end diastolic volume, the amount of blood that enters the left ventricle, and we talked about that as well. And we know that the amount of blood that enters the ventricle changes depending on how much blood is returning to the heart. So all of these things are very intertwined with each other. And we know that this venous return is determined by how much your skeletal muscles are acting on your veins. The more they're pushing on your veins, the more blood is pushed back to the heart. It's also aided by that respiratory pump. So that respiratory pump is, as you breathe in, it takes all the pressure off the large veins in your thoracic cavity, and more blood will enter the heart. So these diagrams here are really good to know, and they're really good summaries of what all the slides are about. So make sure that you know them, make sure that you know each factor, how each factor is related to each other. So these are I can ask questions about, if I change one of these factors, what does it do to cardiac output? So make sure that you know these. Spend some time understanding these charts and understanding the nuances around them, and understanding the how around them. So with heart rate, understand the how. How does the sympathetic nervous system increase heart rate? How does the parasympathetic nervous system decrease heart rate? Make sure you know the how for the actual factor, but also make sure that you know the overall effect on, in this case, the cardiac output. If you know these charts, there's going to be a few of them as we go through this section. It'll be extremely helpful to you. So we're going to end there today. Next day, we'll talk about blood vessels, and we're going to talk about blood pressure and factors that affect blood pressure. So hopefully you have a great rest of your day, and I'll talk to you next time.